Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to a Vento online course by Edu-PIC. I'm Ahmed Saudi, and in this session, we'll talk about weaning of mechanical ventilation. First, we need to know the difference between weaning process and extubation. While the weaning is a slow process of decreasing ventilation parameters and ventilatory support towards completely spontaneous breathing and prepare the patient for extubation, while the extubation is removal of endotracheal tube. It's a subjective process. It depends on the team and the institutional experience. Um, and also the weaning process is different according to the indication of intubation in the beginning. So it's a product of teamwork. Here we have the common indication of intubation and putting the patient on mechanical ventilation. So first it could be the upper and lower airway problem like pneumonia, upper airway obstruction, bronchiolitis, cardiogenic causes like postoperative or low cardiac output or cardiogenic shock, decreased respiratory drive like depressed CNS and coma, neuromuscular weakness like myopathies, and postoperative support after general surgery. Then moving forward, now the patient is intubated and started on mechanical ventilation. Once the patient is started on ventilation, the patient goes through the following phases. So first phase is an acute phase while we are trying to achieve an optimum parameters on the mechanical ventilation to support the lung and improving the lung function as lung recruitment depending on the primary cause. We're targeting non-toxic level of FiO2 with appropriate pressure to achieve a targeted tidal volume. Then patient will move to the maintenance phase. While in this phase, patients need some time for the lung to improve or for the primary cause to improve. Usually, we are manipulating the FiO2 and PEEP actively in this stage. Then, once the patient is improving and the main cause of intubation has been improved, here we reach the weaning phase, while we are going to discuss and how can we do a slow weaning process according to the cause. At this stage, patient will start to trigger the ventilation and have spontaneous breathing efforts. There are different factors can affect the weaning, as we mentioned earlier, type of the disease, also severity of the disease, how severe it is, and if there is any associated comorbidities. Also, patient's age can have an impact on the weaning process, and this is really important factor, the duration of ventilation. The longer the duration of ventilation, the more difficult the weaning process, and it needs a slower process of weaning. So the patient was intubated and ventilated, and he passed through the acute and maintenance phase as we discussed earlier. Now we need to assess the patient, if the patient is ready for weaning and is he fitting weaning criteria, which are resolution of the primary indication for intubation and ventilation. If the primary cause is resolved, and then during the maintenance phase, there's ability to wean FiO2 and PEEP safely. If the patient respiratory rate is almost normal for age, with no increased work of breathing like nasal flaring or intercostal recessions. On the lab criteria, there is no acidosis or hypercapnia, hemodynamically stability, and good GCS and muscle power, optimal fluid balance according to the primary cause, and the PU to FiO2 ratio is more than 270, and the saturation is 94 and above on FiO2 less than 50%. The peak pressure on ventilation less than 20 to achieve acceptable and good tidal volume for age. In addition, there are new indices to assess the patient against weaning criteria, as rapid shallow breathing index, which the frequency or the respiratory rates divided by the tidal volume. And there's some studies showing that if RSPI less than 8 breaths per minute per mil per kilo was found as a good predictor for successful extubation. Also, POCUS ultrasound, lung ultrasound, could be sometimes helpful if it's feasible, like assessing the lung condition, if there is a consolidation, effusion, or congested lungs, or anything that help us to assess a patient against screening criteria. Furthermore, there are condition-related criteria, which means according to the primary cause of intubation and ventilation. For example, for the cardiac patients, it's preferable to patients to be on negative fluid balance to avoid overload, hemodynamical stability with minimal inotropic support, good cardiac function, if there is a feasibility to do an echocardiogram to assess the cardiac function, and patient should pass a spontaneous breathing trial without pressure support, which we are going to discuss later. Then regarding chest conditions, the patient should resolve his chest infection. There's no clinical signs of infection, and improving lung parameters, minimal secretions, and physiotherapy, and there is no lung collapse on last chest X-ray or by clinical examination, equally re-entry bilateral. For CNS causes, the patient should have a good respiratory drive, no seizures. Neuromuscular causes, the patient should have a good respiratory effort and past SPT again on TPs, or patient can be extubated to non-invasive ventilation or other modality of ventilatory support post-extubation. For post-general surgery patient, they can go through the fast track protocol, providing normal and heart condition. Some patients are extubated in theater or shortly after theater, after transfer to the PICU. Now we'll go through the weaning strategies. So the main strategy is to decrease the most potentially harmful parameter. I'll try to decrease the settings according to the clinical response, and this guided by the blood gas, check the parameters on the blood gas and good gas exchange. We limit changes to one parameter at one time as much as we can. We need to avoid any changes in large magnitudes, and we need to document the response. Then we have an idea what parameters and what the next step that we can change following this. And definitely each patient is different, but we have a suggestive weaning protocol which can be manipulated and changed according to the patient's condition. So, for example, we have a patient ventilated in SIMV with pressure support. So we can try to decrease PIP to achieve a tidal volume of around 6 ml per kilo. Then we can try to wean the rate according to the CO2 clearance on the blood gas. After that, we can wean the FiO2 to achieve the targeted oxygen saturation. And this parameter can be weaned faster if the patient tolerated. Also, we can wean the PEEP after that slowly, one by one, according to the primary cause of intubation. Then we can consider extubation while the rate is around 15 or less, and the peak pressure is less than 20 FiO2 less than 40% to achieve good oxygen saturation for the patients. Now we have weaned the ventilatory support to the minimal and the ventilation settings to the minimal settings. We need to assess the patient for the next step, which is an extubation. One of these tests are spontaneous breathing trial, or SBT, which is an extubation readiness test. And the aim of this test is to prove that the patient is able to take a spontaneous breathing and take the responsibility of his own breathing, providing good gas exchange. It can be done in 30 to 120 minutes, and there's different methods to do this test. It could be by a CPAP alone with a PEEP of 5 on the mechanical ventilation, or a CPAP with minimal pressure support. Also, we can use this TPs to provide some PEEP and assist the patient spontaneous breathing, and this also one of method that we can assess the spontaneous breathing without pressure support. Then we can monitor the patient clinically and laboratory and document the response. As we said, we will do this test for 30 minutes to 2 hours. And the timing when the patient on minimal respiratory support, as we mentioned, and minimal pressures and minimal FiO2. And here is an example for spontaneous breathing trial parameters on mechanical ventilation. So the patient will be on CPAP, and he is on minimal oxygen, less than 40%, and the PEEP is around 5, with a zero pressure support, which can be manipulated and increased if the patient needs some respiratory support or pressure support in the ventilation. So now I have put the patient on spontaneous breathing trial to try to prove that the patient is ready for extubation, but maybe I will revise my decision if the patient didn't pass this trial, or we found that the patient is not fit for extubation. So there are some parameters that can help me to make my decision regarding moving the patient towards extubation, or he still needs some time. So there are some clinical criteria or parameters, as anxious, like patient looks anxious, not comfortable. He has increased vocal breathing and nasal flaring on spontaneous breathing trial or CPAP support. Hemodynamic instability, like significant tachycardia, or a patient has hypotension requiring electropic support, has an apneas, diaphoresis. Also, there are some labs criteria, like increase CO2 more than 10 millimeter mercury during this trial, or decreasing the pH less than 7.32, or decrease the pH less than 0.07, increase the oxygen requirements, or decreasing the PO2 less than 60 millimeter mercury with a FiO2 more than 40%. That means PO2 frequent FiO2 ratio is less than 150. Here we have some adjuvant therapy. If I take my decision that the patient is ready for extubation, but there are some risks, so we can avoid extubation failure, uh, as giving steroids. If I found that there is no leak around the ETT, or upper airway obstruction was anticipated, or if the patient has a recurrent intubation, this will increase the incidence of laryngeal edema and upper airway obstruction. Cause of intubation was upper airway obstruction, so the steroids will be helpful. Um, Usually, we use the dexamethasone dose of 0.25 milligram per kilo per dose the day before extubation, and followed by 3 doses of 0.15 milligram per kilo per dose uh, every 6 hours for 24 to 48 hours. If there is no leak was detected, consider not to delay the extubation. If we give the steroids and there is no leak was detected, so it's worth it to give the patient a try for extubation. Then just physiotherapy is another important adjuvant therapy. Before extubation, we can give the patient some physiotherapy to avoid any lung collapse or secretions that be problematic after extubation. Regarding the X-ray and routine X-ray or daily X-ray, there was no clear rule of routine X-ray unless it's clinically indicated. Nebulization with epinephrine can be used in children post-extubation with an upper airway obstruction, but there is no evidence of efficacy in neonates. Caffeine citrate can be used to stimulate as a respiratory stimulant in neonates only, especially in preterm babies. Now we decided that we are going to extubate the patient. Then the next question should be, what should I extubate the patient to? So remember, always depending on the primary pathology, patient history, ventilation duration, and uh, disease course. So I can extubate the patients to room air, to nasal cannula, it could be to the high flow nasal cannula, or non-invasive ventilation could be CPAP or BiPAP. And in neonates, some centers are extubating the patient to head box, but this only on in neonatal units. So extubation is a big step forward, and we should do this step safely. Uh, and therefore, we can use an extubation checklist, uh, which could be consist of the following as clinical and lab criteria, as we discussed, and the patient passed SPT. If yes, team should be aware, like a consultant, senior nurse, and a senior colleague. Uh, this part is a bit debatable to try not to extubate overnight if the team feel safe and the patient doesn't have too much comorbidities, so we can extubate overnight. But if there's any concern, it would be better to be during the daytime while uh, more team members are available and around. Review the last chest X-ray and the blood gas and decide if we need to repeat. Check the ATT leak and if the patient needs a steroid trial. Check if there is a if there good IV access, IV line, in case of the patient needs any medication or resuscitation post extubation. Resuscitation equipment like fluid and adrenaline. I need to be sure that the patient is nilp in mouth and confirm the NGT was aspirated, just in case if this patient needed a re-intubation or there is any reason of extubation failure. Suction physiotherapy to clear the airway before extubation. Try to increase the QRS volume on the monitor. Uh, then you don't need to look at the heart rate or the hemodynamics, but the sound changes during the extubation process will uh, get your attention. Source of oxygen supply like a face mask and TPs and ambo bagging. And if this patient known to have a difficult airway, you should be aware about this, then you can be ready. Get ready for possible re-intubation because sometimes it's not patient are unexpected, so you need to know what the size of the ATT tube that the patient has at that time, and we can prepare a one smaller tube. Prepare a good laryngoscope appropriate to the age and weight. Then post-extubation support should be ready and tested. If the patient is going to be extubated to CPAP, for example, it should be prepared and the settings has been done. And here we have an example for PICU extubation checklist. Then you can tick the boxes and try to extubate the patient as safe as you can. So after the weaning process and assessing the patient against extubation criteria, patient can also fail extubation. So the definition of extubation failure is a reintubation within 24 to 48 hours after extubation. Then if that happened, we should revise the criteria and reassess the patient's condition, try to find out what the cause of extubation and try to fix that to avoid any extubation failure. So, for example, we have increased elastic load, like unresolved lung condition, left-right cardiac shunting, like a PDA or VSD, hyperinflated lungs, significant abdominal distension that increase the intra-abdominal pressure, and the patient has some increased work of breathing and requiring reintubation. The second category is increased resistive load, like thick secretions. That's why we need to be sure that we have a good physiotherapy before extubation. Narrow recluded ETT, upper airway obstruction. The other category is increased minute volume, like pain, irritability, any signs of withdrawal if the patient was on long-term ventilation and long-term sedation. Patient has signs of infection and sepsis, has other causes of metabolic acidosis. Next criteria is decreased respiratory drive, like the patient is still deeply sedated, the sedation not weaned properly, has a CNS infection or other CNS lesion, hypercapnia and severe alkalosis that will decrease the respiratory drive. Also, muscular dysfunction like muscular catabolism and weakness if the patient was not on proper nutrition during the ventilatory support. Electrolyte disturbance, we should revise that. And if the patient has a bronchopulmonary dysplasia and hyperinflation, especially neonates. The other category is neuromuscular disorder, like a diaphragmatic dysfunction. If the patient, for example, post-cardiac surgery and has a diaphragmatic paralysis or phrenic nerve injury, prolonged neuromuscular blockage, like putting the patients on long-term muscle relaxants. Patient has a primary myopathy or there is a cervical spinal injury. So finally, we need to highlight that in PICU, ventilation and weaning and extubation should be a collaborative process and should be discussed between the whole team. And we need to know that each patient is different, and the weaning protocol should be adjustable according to patient's condition and the availability of the resources. It's a multifactorial, which means that including clinical experience and the professional judgment and patient's background. And it's a product of the teamwork, so it should be discussed between the whole team. Thank you very much.